Okay, so this is the part 2 of our understanding hypoxia. So I'll just continue from what I have left. So previously we tried to understand the cellular consequence of hypoxia. When there is hypoxia, what happens to the cell and thereby what happens to the human being as a soul. It is cellular hypometabolism, cellular energy failure, and consequently cellular function is lost, and ultimately there is cellular injury, reversible injury, which may lead to necrosis. Okay, that's as simple as that. That's how hypoxia causes multi-organ failure. Okay, dot simple. So uh, as I previously said, there are four types of hypoxia: hypoxic hypoxia, stagnant hypoxia, anemic hypoxia, and cytotoxic hypoxia or histotoxic hypoxia. Okay, so what is hypoxic hypoxia? The oxygen content of the blood itself is reduced. Okay, so normally the oxygen is 100% saturated, or other in other words, all the hemoglobin molecules are bound to oxygen in the arterial blood. Or in other words, we can say that every 100 ml blood contains 20 ml, volume by volume. Volume percent of oxygen in blood is 20 ml. Or each 100 ml contains 20 ml, 20 ml percent. That is 20 ml oxygen per 100 ml blood. This is the oxygen content of blood. If this oxygen content of blood is decreased, that can cause hypoxia. But what exactly is hypoxic hypoxia? Can I define that instead of 20 ml per 100 ml, it becomes 10 ml per 100 ml? Like this is hypoxic hypoxia? No. Hypoxic, that word means that PaO2 is less. That is the dissolved oxygen is less. So what is oxygen bound to hemoglobin and what is oxygen dissolved in blood? So that so to understand that, we will come to, as I previously said, CaO2, DO2, DO2. But in simple terms, hypoxic hypoxia is desaturation. So if your saturation is not 100%, instead it is 90%, or your PaO2 is less than 60. That is the definition of hypoxic hypoxia. What causes hypoxia? Anything in the lung that will prevent the deoxygenated hemoglobin coming from the venous circulation to get fully oxygenated. It can be a pneumonia, it can be a pulmonary edema, typical examples. Okay, so that is hypoxic hypoxia, desaturation, simple, leave it. Then stagnant hypoxia is the hypoxia due to hypotension. As I said, there is 20 ml per 100 ml of blood, but if the cardiac output is not adequate, instead of 5 liters there is hypotension, the cardiac output is say some only 50%, 2.5 liters, then the oxygen content can be normal, there is 20 ml per 100 ml of blood, but the amount of oxygen delivered to the tissue is low. So in spite of normal saturation, in spite of 100% saturation, the cells can get less oxygen. Okay, initially in hypoxic hypoxia the saturation is low, so the oxygen content is low, thereby the cells are getting less oxygen, so there is cellular energy failure. In stagnant hypoxia there is decreased cardiac output, so the cells are getting decreased oxygen. That's why in hypotension also, ultimately in severe hypotension due to anything, there is a, say some sudden cardiac arrest, cardiogenic shock, a very low because it, or in any syncopal attacks, patient loses consciousness, isn't it? Because the brain doesn't get adequate blood flow. If it doesn't get adequate blood flow, there is inadequate oxygen delivery. So that is another type of hypoxia. So the neurons don't get adequate oxygen, so it shifts to anaerobic metabolism, less ATP energy. Ultimately, everything lands up in cellular energy failure. That's what I want to insist. Stagnant hypoxia is synonymous with low cardiac output, hypotension. What is anemic hypoxia? So we didn't learn that in the previous lecture. So to understand that, you should know CaO2. When the hemoglobin content is low, instead of 20 ml per 100 ml, the oxygen content of blood can be extremely low. Instead of 20 ml, for example, in hypoxic hypoxia, instead of saturation of 100%, if the saturation becomes 90%, so the oxygen content of blood, instead of 20 ml, it becomes 18 ml. So there is just a 2 ml per 100 ml decrease in oxygen content, but that itself is enough to cause a gross cellular hypoxia ultimately. Okay, so you can interpret in stagnant hypoxia, instead of 5 liters, the cardiac output becomes 4 liters, then there is a 20% fall in oxygen delivery. In anemic hypoxia, the oxygen content of blood, this 20 ml per 100 ml, is derived assuming that the hemoglobin is around 14 to 15 grams percent. So instead, if the hemoglobin is only 8 grams, so that is the normal transfusion trigger, isn't it? Less than 8 grams, it's called as a trigger for transfusion. You have to transfuse blood. Less than 8 grams, patient cannot handle that. So the patient cannot survive with health at a hemoglobin less than 8 grams, particularly if it is an acute anemia. Okay. So what if it is 8 grams? Then the oxygen content itself is, instead of 10 ml, it will be only 10 ml per 100 ml of blood. That will be a gross hypoxia. Your BP may be normal, your cardiac output may be normal, your saturation may be normal, but still there will be hypoxia just because the hemoglobin content is normal. How did I derive this 20 ml per 100 ml? It's a standard number. In fact, even ABG reports contain this oxygen volumes percent. If you read all the column, you can see that. I don't know how many of you have seen that. But anyhow, so as I said, anemia at 8 grams, there will be a drastic reduction in oxygen content. So it will ultimately lead to hypoxia. Ultimately, it means that oxygen delivered to the tissue, to the cell, will be low. Cytotoxic hypoxia is the something which is not properly understood. In all these things, we are talking about whether the cells are getting adequate oxygen or not. But in cytotoxic hypoxia, it is not. They get the oxygen, but the mitochondria is not healthy enough to go through the electron transport chain. Even in the presence of oxygen, if the mitochondria doesn't have the machinery to conduct the electron transport chain, that is called a cytotoxic. The typical example is cyanide poisoning. Okay, that's the textbook definition. But the most common thing is sepsis. Any sepsis, ultimately it leads to mitochondrial dysfunction and thereby cytotoxic hypoxia. So your saturation can be normal, your BP can be normal, your hemoglobin can be around 13 and 14, and still there will be hypoxia just because the mitochondrial damage, the mitochondrial injury, mitochondrial hibernation, mitophagy, all these things happen in sepsis. Any sepsis, it can be a viral, bacterial, or even SARS, doesn't matter. So one of the consequences is mitochondrial dysfunction, which means the electron transport chain is not happening properly, which means that in spite of oxygen delivery to the cell, the cells cannot do aerobic metabolism, so there will be ATP deficiency, and so there will be cellular energy failure. Cellular energy failure is a consequence of any sepsis, irrespective of normal saturation and normal BP. In fact, in sepsis at one point there will be ARDS, so the saturation also goes down, and there will also be a lot of hypotension. It's due to disproportionate distribution of blood flow, so inappropriate due to nitric oxide. And moreover, the cardiac output will also at a point may go down. So sepsis induced LV dysfunction, sepsis induced cardiomyopathy. Some people call it as SICM, sepsis induced cardiomyopathy. So there can be a multiple hit in sepsis. Sepsis, initially it is cytotoxic hypoxia. When there is ARDS, hypoxic hypoxia also happens. When there is myocardial dysfunction, this stagnant hypoxia also happens. Okay, so that's why sepsis is bad. And what about hemorrhage? Any trauma or hemorrhage? In hemorrhage, there is acute anemia leading to anemic hypoxia, as well as hypotension leading to stagnant hypoxia. That's why hemorrhagic shock, the hypoxia is develops very rapidly, and it is of a higher magnitude. Okay, these two happens in hemorrhagic shock. All these three happens in septic shock. Okay, now we understand. So all these things ultimately it all leads to absence of aerobic metabolism in this cell, and which leads to cellular energy failure and decreased ATP, and thereby thereby MODS, multi-organ dysfunction, and cell death. Okay, let's try to understand this. So even though I have defined each and everything, now we'll try to understand this. What is CaO2? CaO2 is the amount of oxygen that is present in the blood, oxygen carried in the blood. As I said, it is 20 ml per 100 ml. or in the entire 5 liters of blood in the human body, 1000 ml, 1 liter is one, it contains 1 liter oxygen. You can write 1 liter oxygen is dissolved in 5 liters of blood. Okay, and what is the cardiac output? It is 5 liters. So by pushing 5 liters per, when the cardiac output is 5 liters per minute, the oxygen output is 1 liter per minute. That is called the DO2. CaO2 is the amount of oxygen dissolved in blood, that is 20 ml per 100 ml or 1 liter per 5 liter. DO2 is the amount of oxygen delivered by the heart per minute, that is 1 liter, because 5 liters blood, cardiac output, 1 liter oxygen output. VO2 is the oxygen consumed by the cell, the entire cells of the body. What is the whole body oxygen consumption of an average 70 kg adult? It is 250 ml. So 1 liter is delivered, 250 ml is consumed, only 250 ml is consumed. Remember that heart is capable of giving 1 liter oxygen per minute to the body, but body only consumes 250 ml at rest. Okay, remember this, it is at rest. And so what comes back through the venous circulation back to the right side of the circulation, to the right heart, right atrium, it is 750 ml. So 750 ml, 1 liter is pushed from the left side of the heart, 250 is consumed by all the tissues, 750 ml comes back to the right side of the heart, and the lung again oxygenates it back to 1000 ml. Okay, 750 ml oxygen comes back, 250 ml oxygen is again added by the lungs, and again 1 liter is pumped back to the tissues. So this is how it's happened. When I said 750 ml here, did it ring any bell in any of you? Because in the previous lecture I said the venous oxygen saturation is 75%. Okay, so the arterial oxygen saturation SpO2, what we see is 100%, you know that, but venous saturation we cannot measure unless we do it by a VVG, but it is always 75%. I said venous saturation is 75% and venous PbO2 is 40 millimeters of mercury. But anyhow, the venous saturation is 75% because the DO2 is 1 liter, and out of which 25% is consumed and the remaining 75% is returned back. So that's why 75% is the SpO2. SpO2 is superior vena cava oxygen saturation, or it's more appropriately right atrial oxygen saturation. It's mixed venous oxygen saturation. Okay, 1 liter, 250 ml consumed, 750 ml comes back. Remember this. Now, what is the formula at which I derive the CaO2 20 ml per 100 ml of blood? Just remember that almost this 20 ml, 19.7 is oxygen bound to hemoglobin. Only the remaining 0.3 ml is oxygen dissolved in the plasma. Oxygen dissolved in plasma is contributing to PaO2. That's why when you want to know the oxygen content of the blood, it is all about oxygen attached to the hemoglobin. PaO2 is what is readily available to the tissues. That's why it is relevant. But it's not the quantity that matters. Quantity of blood in PaO2 is not an issue at all. I am insisting this because whenever you ventilate a patient, and you look at the ABG and your ABG shows a PaO2 of 300, it doesn't mean that you are super oxygenating the tissues, because it's a very meager small amount that is increased. Instead of 0.3 ml per 100 ml of blood, by increasing your PaO2 from 100 to 300, you may be increasing to another 0.6 ml. So instead of 20 ml, it will be 20.6 ml. What really matters is the hemoglobin and the amount saturation, hemoglobin saturation with the blood. So the dissolved component is very less, but it is readily available because oxygen has to come out of the hemoglobin. In the RBC, it has to come out of the hemoglobin, come to the interstitial fluid, and then reach the tissue, cells in the tissue. So it's maybe a brain or heart, whatever. So that's why in dissolved plasma is relevant because it is readily available, but the quantity it contributes is very less. Remember this just. Okay, so the formula is 1.32 into hemoglobin in grams percent. So 15 into 1.32 into SpO2 is 100%. So that itself will be 19.7 plus 0.003 into PaO2. PaO2 is 100, so it's 0.3. So it's less just, this is not a theory lecture, so it's not a point in going into details in this. Almost the entire 20 ml is carried in hemoglobin. It's enough you remember this. It is the hemoglobin which makes it possible to dissolve 20 ml oxygen in 100 ml of blood. If there is no hemoglobin, 100 ml of blood can only carry just 1 ml of oxygen. So 20 ml oxygen is, you are able to carry 20 ml just because of hemoglobin. It's enough, you remember that. Okay. And what is DO2? It is CaO2 into cardiac output, as I said. So it is 1 liter. So CaO2 is 20 ml per 100 ml. So 20 by 100 into 5 liters, it will be 1 liter will be the DO2, delivered oxygen. And VO2 is 3.5 ml. Oxygen is consumed per kg of body weight. 3.5 ml per kg. So for a 70 kg, it will be 250 ml. So SVO2, superior vena cava oxygen content, central venous oxygen content will be 750 ml, 75%, and that's why central venous oxygen saturation is also 75%. As I said, almost the entire oxygen content quantity is decided by how much hemoglobin is saturated, isn't it? So 100% saturation in arterial blood due to 1000 ml blood, and in central venous blood, mixed venous, in the venous blood, it is 75%, 750 ml, and it is 75%. Okay, so just remember this. And okay, so it's a very poor diagram, but anyhow, just I want to insist why. What is this 23 and 40 and 100? As you know that this is the PaO2, PaO2. So the dissolved oxygen, PaO2 is 100 millimeters of mercury, PbO2 is 40 millimeters of mercury, and when PbO2 is 40, the corresponding saturation is 75%. You can correlate this only when you picture the oxyhemoglobin dissociation curve in mind. That's too theoretical. I don't want to go into this. So here the oxygen is 100% saturated. When it goes to the capillaries, 25% of it diffuses into interstitial fluid and ultimately reaches the cell to oxygenate them. So by the time it reaches here, it becomes 75%. Okay, this is oxygen bound to hemoglobin. But when you think about PaO2, here it is 100 millimeters of mercury in room air. Room air it is, in room air the PaO2 is 100, isn't it? So from here to here, when it goes, it becomes ultimately 40 millimeters of mercury. So when it diffuses from here to here, it loses almost 60 millimeters oxygen to the interstitial fluid and ultimately going into the cell. And I previously said, when this, yes, central venous saturation is 75%, you might have wondered, I wondered actually. So I just thought that when I read about this in my early days, when I thought that, so what is the entire purpose of desaturation and hypoxia? It just seems to be absurd. It seemed to be absurd for me. Because the arterial oxygen saturation is 100%, venous oxygen saturation is 75%. So instead, if there is a pneumonia or pulmonary edema and saturation becomes say 90%, why don't the tissues only need 25% extraction? So 250 ml is what it gives. If there is saturation is 90%, instead of 100% saturation 90% means the dissolved oxygen is out of 5 liters. 5 liters cardiac output, it's still able, instead of 1 liter, it's transmitting 900 ml, isn't it? Do you understand? With 100% is the DO2 is 1000 ml. With 90%, the DO2 should be 900 ml. So still the tissues only need 250 ml. So I thought from 900 ml, if it can take 250 ml from 1000 ml, and 750 ml can come back through the veins again to the lung. If it's only transmitting 900, what's the big deal? It can still take 250 ml and send back only 650 ml through the veins. That's what I thought actually. But the fact is, the venous saturation, you cannot reduce below 70 so easily to 65%, 50%, something like that. I thought it was possible, but it was not possible due to several reasons actually. Yeah, then when I searched the literature, the textbooks into the basics, I found several reasons why it's not possible. But I am right now trying to give you only one reason. Okay, in case your SpO2 up to, I said up to 90% your body tolerates saturation to some extent, isn't it? There is also some reason for that, as I said. So instead of 90%, your saturation becomes 85%. Let's say 85%. And your body is going to consume 250 ml. That is, it is going to say some 25% out of it. So from 85%, if this is 85%, then this should be 60%, isn't it? So 60%. Is that possible? It's not so easy. So it can't go as low as 60% to handle this. So why? One reason. So as I said, at 75%, the PaO2 is 40. But instead of 75%, if it goes to 60%, this, so this is oxygen hemoglobin dissociation curve, isn't it? At 75% it is 40, but instead if it goes somewhere like 60%, this PbO2 will drastically reduce to somewhere around 20, 25, something like that, somewhere near 20, 25. So when this happens, this has to be maintained somewhere around 40. Instead, if it goes to somewhere around 20, 25, what happens is always molecules move from high concentration to low concentration, isn't it? So here it is 100. Here instead of 40, if it becomes some 20, instead of this oxygen going to the tissues, it will try to travel a easier path to come here. So it won't oxygenate the cells. Your ultimate aim is to oxygenate the cells. That's why I have mentioned this number. Even though the PaO2 is 100, PbO2 is 100, the concentration of, or the partial pressure of oxygen inside the cell in the cytoplasm is 23. Do you want to know what is the oxygen content, oxygen partial pressure inside the mitochondria? You will be shocked to know the amount of oxygen which is ultimately reaching the mitochondria. But I will give you as an exercise, you try to find it out, okay? But anyhow, in the cytoplasm it is 23. So if this oxygen to preferentially reach the cell, this has to be maintained at a higher level. Otherwise it will just go there to oxygenate here rather than here. Do you understand? So this is just one reason. You try to understand, that's all. So the entire purpose is to know that our body is tuned to work at a 25% extraction and try to maintain this SCVO2 near 75%. SCVO2 goes very low only in severe hypoxic conditions. If there is a very severe hemorrhage, hypotension, or and if there is a very severe desaturation, then it can fall. It will fall, of course, 70, even up to 60, 50. It happens, but at a cost of hypoxia. When it goes down, the cells, when SCVO2 falls, the cells also go for hypoxia. There is still hypoxia. That's what I want to insist. So in fact, SCVO2 is considered as a good marker, just like your metabolic acidosis, your base excess bicarbonate, or lactic acid, lactate levels. SCVO2 is also a very good marker to estimate tissue hypoxia. I use tissue hypoxia because ultimately it is the tissue hypoxia matters. Are you having hypotension, or are you having desaturation, or are you having low cardiac output? That's less relevant than whether there is an ultimate cellular hypoxia. Is the cell getting its oxygen? So there is a flow demand mismatch. It is ultimately about adequacy of cellular perfusion, or more properly adequate of cellular oxygenation. Okay, so this is only to emphasize that the body just cannot have a 500 ml cardiac output and take 250 ml back and operate at a 50% extraction ratio. Extraction ratio is, it can be 25%, maybe 30%, 40%. It can't just take the entire oxygen from the arterial blood, and the venous blood can be devoid of oxygen completely. So it's not possible. Okay, I think I try to make a reasonable attempt to make you understand this. So now we will come back. Okay, hypoxia, it is desaturation. So what is desaturation? Instead of 100%, if it is 90%, it means that instead of 20 ml per 100 ml, the oxygen content is now only 18 ml per 100 ml. So ultimately it's going to affect oxygen delivery to the cell. What is stagnant hypoxia? DO2 is affected here. The oxygen content CaO2 is normal, but DO2 is affected. Instead of 5 liters, it is going to be 4 liters. Then the ultimate delivery will be, if it is 4 liters, what is the result? Some 20% reduction from 20 ml. So 16 ml per 100 ml. So the ultimate delivery will be 16 ml per 100 ml. Ultimate delivery instead of 1 liter, it will be only 800 ml. 800 ml instead of 1 liter cardiac oxygen output per minute, it will be 800 ml cardiac oxygen output per minute. So due to stagnant hypoxia. Anemic hypoxia. Okay, that's instead of 15 grams, if the hemoglobin content is only 8 grams, it will be then the oxygen content of blood will be only some 10 or 11 ml per 100 ml. But here see the difference in hypoxic hypoxia and stagnant hypoxia. From 20 ml, a reduction for specifically in hypoxic hypoxia, from 20 ml, if it goes to 18 ml itself, there is silver hypoxia. But in anemic hypoxia, only 8 grams is considered as hypoxia, because most of the time anemia is a chronic process. By that, it takes several days or months, say a bleeding, hemorrhage, something like that, to develop such amount of low DO2, low oxygen output. I will call it as low. And ultimately, the oxygen content is going to be drastically reduced. Instead of 20 ml, to it will coming to 10 ml, then oxygen output. That's why one of the compensatory mechanism of chronic anemia is an enhanced cardiac output. The viscosity decreases, total peripheral resistance goes down, cardiac output easily doubles. That's how it manages. Remember one thing: we are not treating any disease. We are only giving time for the body to heal. Okay, your body compensates for anything, everything, but it needs time. So this is the principle of medicine. Okay, so your body has enormous capacity to handle things, but we have to give that time to the body. Okay, so that is anemic hypoxia. And as I said, cytotoxic hypoxia, it is a mitochondrial electron transport chain. Even if oxygen is delivered, there will be hypoxia. That's why, as I said, a septic patient is hypoxic in spite of a normal saturation. So you understand this various hypoxia. Here oxygen content is decreased, here oxygen delivered is decreased, here again oxygen content is decreased but in a different way. Here oxygen delivered is normal, content is normal, but the cells are not using. So this is the only type of hypoxia where, do you have any difference between these three and this one? This is the cytotoxic hypoxia, is the only hypoxia in which SVO2, the venous oxygen content, is more than 75%. It is always more than 75%. Okay, all these conditions it is less than 75%. Here it is more than 75%. Okay, so in fact, SpO2, venous oxygen saturation, is becoming a very important marker. It's always present. There are methods to estimate the venous, and right now it is the VBG. There are various even non-invasive methods to detect VBG. I can't say non-invasive, but it is a sensor-based continuous output. Some devices are there. It has become a good marker to detect hypoxia. In fact, more than 75, if it is more than 75%, some intensivists try to using the term hyperoxia. Even in this COVID scenario, in this COVID scenario, people say that in spite of a low saturation, say a patient is having a saturation around 90%, and you take the central venous sample, and if the saturation is more than 75, then there is no point in giving oxygen to them, because what is the primary problem here is cytotoxic hypoxia. So cellular hypoxia, mitochondrial dysfunction. Even if you give oxygen, it is only taking this 15 ml or 15%. From 90%, it is, even though SpO2 is 90%, it is only 75%. So with oxygen you are going to make it 95%, then your SvO2 will increase to 80%. If your saturation is 100%, SvO2 will become 85%. Without the underlying pathology getting corrected, mitochondrial dysfunction get corrected, we don't have specific drugs for that. We have to treat the primary cause and give time for it to recover. That's what we can do right now. But it gives an information when you understand cytotoxic hypoxia, and you see a normal or higher than normal SpO2, you know that there is no point in damaging the patient with mechanical ventilation, so the barotrauma, or with high FiO2. High FiO2 causes denitrogenation atelectasis, isn't it? It causes atelectasis. Most of the time, oxygen can be damaging. I can even use the word oxygen is a drug. Oxygen is not just a supplement, okay? It is a drug. That's why by nature oxygen is only present in 21%. The remaining nitrogen, 79%, it has a purpose. It is the nitrogen which keeps our alveolus without collapsing. Okay, otherwise it will, the alveolus will collapse if it is if nature gives you 75% oxygen or 100% oxygen. So we cannot give a patient 100% oxygen in the ICU just because saturation is low. We have to be very clear if there is a cellular level hypoxia in that patient. Okay, of course it's very easy to say, but practically we have to individualize each patient. We have to decide whether to give oxygen. There we can see the clinical picture, we can see the ABG, there is a lot of information available, and decide. I don't say don't give oxygen, but don't at least give a high FiO2, or don't put them on ventilator without a purpose. Okay, so the importance of SvO2 is emerging gradually. It's not a very popular thing. It's not known to everybody. Not everybody will measure SvO2. Of course, we very fondly measure VBG, central venous samples, because it has given us some good insights. Okay, so I will give you an example and conclude with that. This is a sepsis case. Okay, sepsis or cytokine storm modes, whatever is. This is a COVID case. Okay, let's be frank about it. So this is a COVID case which had a poor outcome, and you can see the pH is 7.24, and PCO2 is grossly increased. So that's because of damaged lung. So the lung was damaged. Only 25% of the lung was functioning. So it's expected. So the PCO2 was very high. So forget other things. At least look at the PO2. It is 79, and look at the SO2. It is 94%. The patient is maintaining 94% in spite of a very small lung. It is maintaining 94% with some oxygen polymask. We are using polymask 94%, and it's 79. The patient gave a very clear do not intubate order. So we couldn't do that. But anyhow, I don't think that would have served the purpose also. But 79 PO2 and SO2 94%. Just keep this in mind. This is the arterial sample. This is the venous sample at the same time. PO2 is around 55 and your SO2 is around. So here it's SO2. This is nothing but SbO2. Okay, venous sample. This is the venous sample. So for a saturation of arterial saturation of 95%, venous saturation of 84%, in spite of the fact this patient is tachypneic, starving for oxygen, damaged lung. So the venous saturation should be very low, somewhere around 60s or 70. But why is it 84? Because even if oxygen is delivered, even the amount of oxygen delivered is low, but even that amount of oxygen is not consumed by the cell. That's why your central venous saturation is 84%. Okay. Will this patient benefit by a 100% FiO2? No. The lung will just get damaged much more. Okay, so do you understand this? So this patient has a combination of hypoxic hypoxia as well as cytotoxic hypoxia. But this cytotoxic hypoxia can be detected by taking the central venous sample, and it also dictates whether this patient should be given higher. I don't deny that this patient will, I don't say that no oxygen, leave it in room here, but there is no point in doing further lung damage by a very high FiO2 and ventilations. Okay, barotrauma. Okay, so that's anyhow, it's a very sensitive issue. Technically, it's not a guidelines. It's not a clear-cut guidelines given by any prominent associations. It's only very few papers are published regarding this. Not everyone agrees, but I believe strongly, because oxygen is a drug. Oxygen is a drug. Just like adrenaline, adrenaline is a lifesaver. When there is a cardiac arrest, you give 1 cc. Probably the patient may be completely normal. Okay, with proper CPR and adrenaline, you can revert a cardiac arrest, revert a death. It's a wonder drug. But can you give adrenaline in a patient who has a normal BP? So he will kill the patient with ventricular fibrillation or intracerebral bleed. Just the same way, oxygen is also a drug which should be used sensibly. Okay, thank you.